Hello again, everybody. Welcome to another version of Accreditation TV, brought to you now by or it's no longer the Accreditation Network, it's the MSL Ready Now community. So we're excited about that. It's brand new. For those of you that haven't visited our website and seen that, please do. It's free to join. All these videos are free. So if you're one of our MSL Ready Now partners, then and you want the CECs for this, and make sure you let us know because we want to provide those to you. And if you want to learn more about that, please let us know. We'd love to talk to you. So today we're going to talk a little bit about patient information. But before I get to that, I'd love to introduce our special guests who are familiar faces at this point. So we'll start out with Ramona Cheek, who just brightens everybody's day. It's a great way to start any week, anytime with Ramona. And so we're glad to have her. And then we have Tim Adams, who everybody knows Tim. So we appreciate his background, of course, his facilities and clinical engineering. And Ramona's is the nursing and CNO and lots of other things. So, I don't want to say we're old, but when I first started thinking about patient information, we all started in an era when patient information was just, you just talked about it. You just walked, it wasn't real. I mean, you tried to keep it confidential, but there was no real, it was pre-HIPAA, I guess is the way to describe how our career started. So we've seen a major shift in what is allowed and what is appropriate in terms of patient information. But I want to talk a little bit about, what are some of the challenges from both of your perspectives that you've seen in terms of guarding patient privacy and their information in today's world, not just from a HIPAA perspective, but in general?
Yeah, I think when you're talking about PHI or, you have to consider 2 worlds now, the electronic world and the paper world. And the other thing is that it's not just things that are written down, but it's also verbal communication. So a big thing that you still have to remember that we did do in the old days, Steve, that we still do now, is that you get on the elevator and you listen for conversations that you can overhear that people are talking about. And there's some vulnerable areas of where people have a tendency to be more relaxed and talk about patient information or patient stories that give away some identity that they shouldn't. So it's also making sure that you are aware of when you're speaking about things. When you're talking about PHI, it comes in a couple different categories, and Tim is going to talk a little bit more about from the environmental side. But you're worried about confidentiality of the medical record, and a lot of times now that is electronic. Minimum necessary access to that information. So, who has access to the information, and how are you tracking that access? And a lot of times, it's how are you tracking that access because it's fairly easy for anyone to sign up and sign into the electronic medical system and get a hold of information for a specific patient that they don't have any right to. It is not on a need to know. It's not their patient. And that's something else that we really have to be aware of and monitor for. So we look for our IT people to give us reports about who has been into charts that they shouldn't have any business, and that's both clinical and non-clinical, both physicians and non-physicians. In the old days, primary care physician or any physician would come and say, "Oh, that's a friend of mine. Let me look and see what's happening. Let me look at their record." If they do that now, that is an infringement on HIPAA. I mean, and even people need to realize, even if I'm an employee working in a hospital and I want to check my own medical record for something and say, "Hey, I know my medical record number. I can look up. It's just my own information." That is a violation. You have to put in writing when you want access to your medical record. You have every right to look at your medical record, but you have to go through the right channels. And just being able to put in your medical record number when you're working to look up your chart is an infringement, and you can get canceled because of that. So realize that. And I already talked a little bit about the secure handling of verbal, paper, and electronic um, information. also what comes under this a little bit is the authentication and integrity of documentation. So we spend a lot of time talking about whether or not, it's signed, it's dated correctly, and the right person is putting in the right information. So that's something that also comes under the general umbrella of PHI. And then I think in our modern world, the thing that we have to remember to keep contact with is texting,
Hmm.
and what devices people are texting on. We have a new generation of clinicians that are used to texting. That is their primary way of communicating, and they're used to texting on their own personal phones. Everyone carries their own personal phones. And if something, I'm a nurse, something has happened to a patient, I'm grabbing my phone and texting that physician that this has happened. Well, if that's not secure, or if that's not, your phone isn't recognized as being a device of the hospital, um, then you could be opening yourself up to some HIPAA violations. And the physician that receives that, if that's not a secure phone and you're not doing secure texting, they also could be open. So that's something that we have to pay attention to in today's world.
Yeah, I mean, that's one of those things. And until I shadowed you on a survey, I never even thought about it. But is that something that you would expect the hospital policy to address? Is
It
use the
does, and
person?
and these days it causes some, a little bit of controversy, and how hospitals handle it is different. There are some hospitals that say, yeah, you can use your own phone, and we will make sure that you have all access to securing that stuff. But that means that we have access to all the information that is on your phone, and we can, and in case of cybersecurity, we can shut down your phone and that pathway. In other hospitals, they give you a separate phone to be able to do all of those things so that you know it's secure. It's the hospital's phone, and it makes sense. They own all that information on that phone, and if they have to shut something down, they're just shutting something down on the hospital-owned phone. So it gets a little bit tricky when it's your phone, but you have access to just checking your schedule. A lot of people are downloading their own hospital schedules on their personal phone. Well, that gives the hospital that is an entryway into the hospital's, IT system, and
Yeah.
opens a hospital for, maybe some cybersecurity issues. So if they have to shut it down or shut down a pathway, that could affect your own personal phone, and people have that is worth a discussion, in your organization to find out what that means, and then what can the hospital do to secure their own information via your phone? So, it's interesting and something that we didn't have to I frankly didn't think about it until it's like, "Oh, wow, you mean my phone can be shut down? I might not be able to access part of my phone because it has hospital information." Um, it's a different time and a different way of thinking about it. So it's good to talk with the privacy officers in the organization to be very comfortable with what your policies and procedures are in your organization that governs that things.
Yeah, I mean, that's a great point. And I mean, we talk about security here in a few minutes. So there's a lot of different aspects of that we should probably address. Tim, I know, from a physical environment perspective, um, you've had some observations about how to protect privacy as well. And you,
Yet it's important to consider what can a person see when they're walking around, because there's a lot of people walking around. I've found many times a workstation on wheels, a computer on wheels sitting in a corridor where somebody has been using it. Or as the life safety side of things, the first thing is that in use or is that not in use? But more importantly, perhaps, is the fact that there's patient information on it. Somebody's name is still there. And if I wanted to, could I gather information or remember that? Um, and, then what could I do with that? So, just what can people see? How secure is that? And unfortunately, most hospitals, especially older ones, but sometimes brand new, we still don't quite get this right. There is no real place to be able to work at a computer, and they end up in the corridors. And people are walking up and down the corridor. How much can you see? And I know there's different kinds of screen protectors or things you can put on there that you have to be square into the screen to see it, and that's probably a really good idea. But being sure that our electronic things don't have information people can see. If there is some kind of central monitoring in a nurse's station, if somebody's walking by that nurse's station, can you see that? And does it have a name? Sometimes it's a first initial and a last name, but even that, could somebody put two and two together and figure out who that is? So, one aspect is um, just being able to observe things on computers as you are, or on monitors as you're walking through a facility. Another aspect is training staff and contractors, vendors, those who come work in facilities about privacy. We probably do that with staff. Everybody has annual education that um, most of them do it online now. So the whole trick is, can you not pay any attention to it and still pass the test? But I shouldn't say that, but unfortunately, people look at it that way sometimes. But
Yeah.
we do have that routine training about guarding personal information. But what about service personnel, contractors, um, sales vendors that come in and are in departments and are around that might see someone they know who is a patient, and keeping that private? It's and it I could say, and it probably is more frequent that it happens in a small town, but it can happen in the big city too, where you go in and find that your aunt is in the hospital with cancer and you didn't know. Well, maybe your aunt didn't want people to know. That's her, that's her right. And so we have to train and remind those who are working in our facilities, what you see stays here. You don't go out and spread or ask, even out of goodwill, and that's hard to do. You really want you because you can't. It's not because you want to be nosy. It's you saw somebody in the hospital, and maybe you saw somebody in behavioral health, um, and you had no idea that they had anything going on. You want to find out maybe because you really care, but we cannot spread that. That is their right to their privacy and to share whenever and however they choose to. So that becomes another aspect that was very hard to keep a handle on when you think of how many people come through our facility. For those who do, and I know many hospitals provide an orientation for anybody who's going to be working as an outside entity working in the facility, provide training and a little bit of first time you come in, this is what we expect. Um, be sure that that is included in that. That
Yeah.
what you see stays here. Names of people. You don't share that you saw so and so in the hospital. Um, let
Yeah.
them do that at their will.
Yeah, Tim, I 100% agree with you. And in fact, one of the most recent Joint Commission frequently asked questions had to do with contract workers and their access to information. This question was specifically around an ambulatory office who had a contract with an outside cleaning agency, and they had medical records. And in the office, even though everyone they did have the training, the employees had signed a confidentiality agreement. They did not lock up their medical records, and they were wondering if that was okay. And Joint Commission kinda said, I would get your risk management and legal involved, but we really feel like in that instance, a confidentiality agreement is not gonna be enough, and those records should be locked and secured that housekeeping does not have access to it. And I think frequently on our mock surveys, that is what we find. There are medical records in those ambulatory offices, and after hours, there are people they're behind a file, but the file isn't locked, or in a drawer, but the drawer isn't locked. There are people that could have access to it. So I think people, as part of their survey and environmental rounds, need to look and see, is there anyone who does not have access to that information? Are they able to get to that information?
Yeah, it seems like a situation that's probably far more prevalent than we realize. Because it seems like a lot of these ambulatory areas are, and the focus on ambulatory areas now with A360 and some of the other AOs is probably going to surface a lot more of this because we're going to be spending more time in those spaces than we have in the past. But um, yeah, it's been one of those common things. I would think a confidentiality agreement would be kind of weak. I mean, when considering all the BAAs I signed that are pretty locked down, um, but that's an interesting. I'm glad you brought that up, and thinking about it from the perspective of the built environment again, Tim. It feels to me like, from a design perspective, we're probably a few years behind technology in that, we build these spaces and we don't really think about where the tech's going to go and fit into the spaces. And the one thing that seems to pop up a lot too is just the whole audible thing. It's like I can hear what's going on in the room next door. Experienced that on a personal level recently. It was an older building and a clinic, and having the clinicians, the providers were having a conversation with the patient next to us while we were waiting, and you know pretty much heard it all.
Hmm.
So those are things that again, Ramon, I think you touched on it when you're doing those environmental rounds and tracers. You should look for those kinds of vulnerabilities and try to figure out the best way to resolve them. I mean, obviously you can't resolve all of them, but you want to try to definitely resolve as many as you can. And the whole conversations in the corridors and the elevators and all that. I know that's one of the bigger challenges as well. From a security standpoint, you kind of touched on it, with the ambulatory care in terms of just locking spaces up. But when we think about it from the broader sense, it's like how do you guarantee, or at least guarantees probably too strong, how do you minimize the potential of a security breach, if you will, of privacy? And I guess now in today's world, the most obvious way to do that is through some kind of IT intrusion. um any thoughts around that?
I know, we think a lot about cybersecurity, and
Yeah.
um, most surveyors will want to talk about that at some point during the course of a survey. The
Yeah.
part of cybersecurity is protecting the patient's privacy. And there's many, many other things that uh, someone could get into a system and do all kind of malicious things. But one is the release or the availability of healthcare information. How many times have any of you received a letter from somebody, an insurance company, a healthcare organization, um, anybody, a credit card company that says there's a possible breach in security, and we recommend you do this, this, and this. Um, it happens a lot. Happens a lot, and healthcare organizations are particularly vulnerable to that. So being sure that you have robust systems and processes in place on the IT side to prevent unauthorized access. And sometimes that unauthorized access doesn't have to come from outside. It can come from inside, somebody who has access to the system but is gathering information for whatever reason, maybe just trying to check up on a friend or you know something.
Yeah.
But not all security breaches come from outside. Somebody inside the system could potentially access patient information also.
Yeah, I mean, one of the things that I think a lot of people don't even think about is the number of systems and devices that are now on our networks. And particularly, I mean, as we become much more technology dependent and enabled, simple things like building automation systems, fire alarm systems, monitoring systems, medical equipment that touch our systems or connected to our devices. All of those provide an opportunity for someone who's smart to gain access to the network. And if they're able to penetrate properly, they could get all the way into patient information or worse, the pharmaceutical, whole, I mean, there's all kinds of opportunities at that point. And I don't know how many people are aware of it, but when, Target, the store got, I think it was, yeah, when they were breached, it came through their building automation system, right? There was a panel that was available, and they were able to access that panel and gave access to Target's network, and then the world was their oyster, so to speak. So we really had to think about those things. For a minute, you were about to say something, and I interrupted you. I don't.
Oh, no. Well, I would say there's just, yeah, tons of different ways. I know that in organizations, they spend a lot of time talking about the malicious phishing um, um, things that emails that happen. And so IT has to be really on their toes to teach the people and to monitor everything and testing and making sure that they're able to assess what the vulnerabilities are and that they are constantly looking at that information. I know that I, as a CNO, many times would get reports about people that look like it might have been unauthorized access to information. It's like, wait a minute, why is this person on the oncology floor looking at a chart on the maternal child floor? And
Yeah,
you'd have to kind of investigate and say, was there a need to know or not need to know? I mean, so it's things like that that you just have to constantly be on the lookout for. And for those phishing emails, I mean, they will send out regular malicious, pretend emails to see does staff pick up on it and do the right thing, which is not open and send it to right to the IT department. So there is a lot of activities, and it's getting more and more to protect cybersecurity and the way and your vulnerabilities of getting into your information management systems.
yeah.
And even an
Go ahead.
old-fashioned way that we still need to think about a lot is, and speaking of Tim and location of the environment, it's like, where are your fax machines? And there's still some hospitals that use fax machines, especially on the ambulatory side. And where are your printers located? And are they located in an area that gives you that the public has access to? Because a lot of times we used to put printers in the hallway because if the nurses were printing, we wanted to make it convenient for the nurses to be able to get it. And well, that's a great thought, and we need to keep, the burden of our nurses in mind. From a privacy standpoint, that's not where you want your printers. You want it in a secure area. You want it in a place that's behind locked doors or someplace that you cannot have only those authorized have access to. So those are the things that you have to think about, to Tim's point, in the environment when you're designing, where are you going to put those things?
Yeah. Well, I mean, that's all good stuff. Go ahead, Tim.
As I say, and that taking that printed piece even farther is how do you manage it when it leaves the building? So if you're getting rid of records and such like being sure those are shredded um, in in-house or on site before they leave. And many hospitals have a way of doing that. They'll have special containers for shredding and somebody that comes in and does it or some way that they get that done. But the offsites are the ones that maybe worry me the most is do they have that capability or their things shredded on site or is it bagged up and taken somewhere else to be shredded? How secure is that information? Just something as simple as somebody writes on a scrap of paper a patient's name and some piece of information about them. That gets thrown in the trash. And I have heard stories. I can't say off the top of my head I remember a specific organization or date and time, but where paper ends up in a landfill that blows around and has patient information on it. So
Yeah.
that security all the way to the end to when it is no longer readable is important. And as we become more electronic, we don't have maybe as much paper, but there's still a lot of it.
There is. And I think you bring a really good point about the shredding companies because a lot of times when you have the shredding bins on the unit, but then the shredding company comes around, empties those shredding bins into an open container Um, and then forget and then gather it all. And I know that this is a sighting actually on a mock survey, had left an open bin of all that information. And they thought just for a second while they got the truck, but there's a huge bin, I think a couple different trash cans full of patient information that was unattended. I mean, and so they have to kind of think about their process so that each step of the way, that information is attended. Yeah. Yeah.
Yeah, it's interesting because I witnessed not long ago a situation where a nurse at a nurse's station, the medication rooms in kind of in the centralized part of the nurse's station, the charting station is out at the desk. And, she gets an order and she goes, she leaves the screen active because she's walking maybe 5, 6 feet away, swiping the door, opening up Pixis, grabbing a couple whatever's out of there. I don't know. I'm not a nurse. I don't even play one on TV. Grabs that stuff and comes back out. And maybe that whole process took 2.5, 3 minutes. But that screen was active the whole time.
Mhm.
And in my mind, technically, breach. Reality, unless someone were to walk up to the nurse's station, unless they're like, Steve Austin with a bionic eye, by the way, that's an age test for the people who are watching it, because most people have no idea what I'm talking about. But you're not going to be able to read that sort of thing.
Right. Right.
But going back to your point, huge bins full of PHI, I mean, most, just human curiosity, I would walk by and I would, what's in there? Next thing I know, I've created that breach just being curious. So, gosh, time flies when we're having these discussions. I want to, before we wrap up, though, I do want to talk about, from an accreditation perspective, where the surveyors are likely to pick up on some of the challenges with this. So, Ramona, you mentioned a couple of things when we were talking. I don't know if you want to go first, ladies first.
Yeah. I would say what they consider the highest risk departments right now are the emergency department, and usually it's around the registration area that opens up into a big waiting room where they're getting information and you can hear all that information that's being shared. So that a lot of places they have, toned down the registration is a little bit removed. There's more glass barriers around. So they've made attempts. Now you're not going to be able to mitigate everything, but you want to make sure that you've mitigated much of that. And so that's a vulnerable area. The labor and delivery room for the same area because they have they've posted the C-section, schedule with the name and the time and some information on it, and that might be open to public access. So they just need to make sure where they have those whiteboards or electronic boards that patient identifiers are blinded. So, it's either done by numbers that only that patient or the family has a number, the corresponding name that goes with that number. And that is in the same with OR and OR waiting rooms. Radiology, case management. Case management, interesting enough, it's usually because case management is sometimes removed. The department is removed a little bit from the acute care setting. But if you go, there's lots of patient information and they forget to lock their offices when they leave, and that is in a public access corridor. So you just have to kind of pay attention to that. And lab collection areas, because there's a lot of information being exchanged there. People might be putting labels in places where identifies the patient's medical record number and name, and getting ready to do the right thing with the correct labeling, but it's in an open place where other people have access to that information. I also want to talk a little bit about what they're considering now for 2026, the top 20 PHI findings that have been found so far. And some of these are not, we've already talked about a lot of these, but one, it's unattended logged in workstations that Tim talked about. Now here, shared generic logins too. So you have to be careful about if there's some places do have shared logins to get into the system, and then you have to then personalize it, but make sure that you can't get through that shared generic login information that you don't have a need to know. So just kind of assess that. We talked a little bit about patient labels being left at printers. Census sheets. A lot of times people print out their census sheets and leave it right there on top of the nurse's station. And they do that so other people have access. Housekeeping wants to know who's being discharged, and they're putting discharge, but there's a lot of information on those sheets or on those boards that might be visible to the public. Tim already talked about the hallway computer screens. We talked about staff discussing patients in public areas that you're overhearing things. Um, Verbal bedside reports, which is a big thing in nursing. We encourage bedside verbal reports, but you want to make sure that you've taken the necessary steps to protect that privacy as much as you can. Now, sometimes they realize that the gains that you get from communicating information, you're going to give up a little bit, especially in semi-private rooms where the only thing that's separating it is a curtain. And we know that. I mean, so but you talk about that in your policy and procedures and talk about what's the things that you have done to mitigate that, in that you're conscious of the volume of your voice. Sometimes you might have white noise in the room to disguise that. So just be aware of that. And we talked about personal devices, and it's something that I'm sensitive to, because we take pictures all the time when we're coming in to do a mock survey. So we have to be very careful when we're taking those pictures, that there's nothing that is identifiable in those pictures. And we also have to make sure that staff, when they're taking pictures or doing TikTok videos, or whatever, that you're not able to identify things because of that. Um, Tim already talked about vendor or contractor access to information. The discharge papers, face sheets, or things. I mean, there's always even though we're gone electronic, we always have paper, and we just need to make sure that those paper things are not left behind or left in the transport office or whatever, so that people who don't need to know have access to it. We talked about specimens. We talked about the shredding containers. And we talked about medical storage rooms. And we did talk about the necessity that people of IT and the privacy offices of doing audit trails to see what is the security around records and what are your vulnerabilities, and that you're always working on that. And then we talked a little bit about role-based, not I mean, the need to know means that you need to know about what's happening with that patient for that particular just because I'm a nurse working, or even as a CNO. I mean, one of the things that I was always really proud of is that I did not know who was in the hospital unless the patient said, I want Ramona to know that I'm in the hospital. Otherwise, my staff did not tell me as a CNO that this person is in for me to do a visit. So that's something else that people need to know. I mean, unless a patient says you can release the information, I don't know who's in the hospital or why they're in there. So that's important that people know who's access to information based on their roles.
I had to laugh a little bit. You triggered a memory for me when I was in the hospital. I was there for like 4 months in rehab, and you're talking about the verbal reporting, or between nurses at shift change, and they used to literally do it across my bed because I'd been there forever. And I was in a semi-private room. My roommate Carl and we knew everything about every patient in rehab because they would just come in and do report like across my bed at night, but it was entertaining for all of us. So anyway, yeah, times have changed. What's that?
I said entertaining, but not right.
Yeah, I know. Well, back then it didn't matter, but times have changed a lot. It's just remarkable to me. But
Yeah.
so, Tim, you got anything else you want to add? I think we might have lost Tim there. Um, so I will.
Hello?
Well, I'm gonna assume. Oh,
Uh,
nope, we didn't lose him. There he is. So, do you have anything else you wanted to add?
I think Ramona covered it's being very careful, just that physical, what you can see. It's not just what you'll see and remember, it's what your phone can take a picture of, or somebody's phone. And it's
Yeah.
so easy to snap a picture of a screen or a person or whatever. Um, just being very observant as you work in a healthcare facility of what people are doing. I was doing a survey 3 or 4 weeks ago, and the way it worked out, 2 of the days I was on my own. I had keys and a swipe card, and I had a name badge from the facility with my picture on it. I went through training to get that. And there, but I would just walk in departments and be looking around, and if I saw somebody, I would always check in, but sometimes there's nobody around. And I had several departments, somebody asked me what I was doing as I'm looking through things. And I appreciated that.
Yeah.
And there'll be a comment about that. They were very polite, but hi, could you tell me what you're doing?
Yeah.
Just being observant for those, maybe it's, there's nothing malicious going on, but could somebody be inadvertently or on purpose gathering information, and just having an eye out for that.
Yeah.
I think a
Awesome.
good question to ask staff and employees is that, how do you protect patient information, and then hear what the answer is that they give to that question, and that will tell you a little bit about what things you need to educate and what things that you've done a great job on and people get it. So
Yeah, and I think you guys, when we're talking earlier before we started the live session, you mentioned that the cybersecurity component of the survey typically happens during the emergency management discussion. So for our physical environment and non-clinical people out there that might be watching this thinking, well, this is not really my issue, be prepared, because you might be talking about how you protect patient information during the emergency management session, or any other part of the discussion, because Ramona pointed out early on, we were having a discussion, is like that cybersecurity is so much broader than just patient privacy. It's because as we talked earlier, it touches on so many pieces, areas of the hospital. So, well, guys, I really appreciate it. It was a great conversation, and for those of y'all that are out there, I again forgot to say put questions in the Q&A, but I guess it's a little late now. We'll be happy to answer those. Please jump over to mslhealthcare.com and the MSL Ready Now community. You can just follow the community tab at the top, and you can join for free. If you are interested and you want to become one of our partners, please do that as well. Provide CECs and a whole lot more. You get access to people like Ramona and Tim to answer questions. So we look forward to hearing from you. Thank you very much for your time, Ramona. Tim, thank you
yeah,
very much. You guys
Thank
have a great
you.
bye bye.
rest of your day. And we
Have a
will
great day.
see you in the next one in 2 weeks. Thanks.